So welcome everyone. We're going to get started soon. Thanks for being here.
Looks like people are streaming, and maybe we'll give them 1 minute.
Great.
Wow, I'm looking at all the people signing in, and it's really amazing. We have people from Las Vegas, India, somebody from Manila, somebody from America's chocolate town, Hershey. It's really exciting. Okay. All right, why don't we go ahead and get started? It's 3 after the hour. I wanted to welcome everybody who's joined us and who is in the process of joining us to the 21st episode of ATS's Critical Care Training Forum. It's hard to believe that it's been more than 6 months now since the pandemic officially began in the US, and we're still learning as we go on, attesting to the popularity of these forums. I'm Dr. Angela Wang. I'm Medical Director of the Outpatient Clinics at UCSD, and I'm here with my co-moderator, Dr. Ni-Cheng Liang from Scripps and Mdis. The title of today's session is Management of Asthma and ILD During the COVID-19 Pandemic. I was just thinking today when I was just looking at a couple articles that the bulk of the literature up to date has focused on care of inpatients during this pandemic, and obviously because they are the sickest of the sick, but the vast majority of the patients obviously have been cared for at home. And one of the ongoing challenges for outpatient physicians has been, how do we maintain the care of our patients and how do we adapt the care during these tumultuous times? And so with that, can we go to the next slide? We've assembled a really exciting panel of discussants today. We'll be leading off with Doctors Jisha Joshua and Brinda Desai from UCSD, followed by Dr. Joshua Solomon from the National Jewish, who will be discussing a case of IPF with COVID-19. Dr. Joshua will also be lending his expertise to tell us about the increasing numbers of post-COVID fibrosis that we are seeing. And then they will be followed by Drs. Stephanie Christenson and Aartik Sarma from UCSF, who will be discussing the management of asthma. So the objectives for this session, as you can see here, will be how do we adapt our workup and management of COPD, asthma, and ILD during the current pandemic. Hopefully we'll all learn more about how to appropriately manage these patients with pre-existing lung diseases and COVID-19 infection in both the outpatient and inpatient settings. We'll talk about the effect of COVID on the prognosis and outcomes of patients with pre-existing lung diseases. And then, as mentioned, also discuss post-COVID pulmonary fibrosis and what we know thus far about its pathophysiology and treatment. I want to remind everybody that today's session is not, repeat, it is not CME accredited. However, we do value your evaluation, so please fill out the form. We use your input to help design further sessions and to make each episode better. And with that, I'm going to hand off to my co-moderator, Dr. Liang.
Thanks, Dr. Wang. So just a reminder for everyone, we have a wonderful library of additional critical care training forum sessions that are available on the American Thoracic Society website for your viewing. There are already 19 episodes on there, and this will also be added on there after the session. So you can search for ATS COVID forum or use this URL here. And then in the near future, we're going to continue the critical care training forum sessions, including COVID-19 in patients with HIV, lung transplantation, as well as updates regarding vaccine development and the immune response in COVID-19, along with ECMO. And we'd like to thank the chairs of the Critical Care Training Forum, Dr. Laura Crotty-Alexander, Dr. Nirav Shah, Dr. Sushma Kribbs, and Dr. Viren Kaul, along with the trainees on the team and, of course, our ATS staff. Thank you so much for everyone's support. With that, we will turn it over to Dr. Desai to present a case.
Thank you. Let me start sharing my screen here. Can you guys see the screen? Okay. All right. Let me know if anyone can't hear me. Hi, everyone. We're going to present a case from our clinic here at UCSD. This is a patient that Dr. Jisha Joshua follows primarily in her clinic, in her ILD clinic. So a little bit background on our patient. He's a 61-year-old former smoker, history of COPD, who was referred to the ILD clinic in March of 2020 for progressive shortness of breath that had begun since 2015. When he was initially seen in ILD clinic in March of 2020, he did have pretty significant dyspnea, would get short of breath with 3 blocks of walking or climbing as little as 10 stairs, did have to rest and then kind of recovered on his own. At that time, he was not on supplemental oxygen. As far as past workup goes, he had quite an extensive amount of workup done, no inhalation exposures, negative autoimmune workup, negative infectious workup also. And then this is his initial CT. This was obtained earlier in 2020 at the beginning of the year. Typical pattern for what we see with IPF and paraseptal emphysema. Let it play through here. And this was just partly, this was the initial workup that we had done, or just kind of review of his case when he first presented to our clinic. Oops, sorry about that. So as I said, typical UIP pattern of pulmonary fibrosis and paraseptal emphysema. He had baseline PFTs at our clinic. This was done in February of 2020. So kind of just pointing out some of the factors we have in here. His ratio, if you notice, was it was fine. It was not decreased. His TLC was actually also normal, didn't show patterns of restriction. However, if you notice, his DLCO was significantly decreased. So this is kind of where we started off with back in February of 2020. We had a multidisciplinary case conference in April of 2020 with the diagnosis of kind of discussing, is this idiopathic pulmonary fibrosis versus combined pulmonary fibrosis and emphysema. And from the multidisciplinary conference, the plan was to start him on antifibrotics with lab monitoring, diuretics, and inhalers, and then referral to pulmonary rehabilitation. However, his case was complicated by getting insurance approval for his antifibrolytics. So now kind of going into COVID-19 pandemic, meeting ILD and kind of what happens in our patients. So this particular patient, in May of 2020, he started having new onset fever and body aches for 2 weeks after having a positive exposure. He was diagnosed with COVID-19 and admitted to an outside hospital from the end of May to the beginning of June. Initially, he was treated with convalescent plasma, was hypoxic into the low 70s, and then discharged on home oxygen and as needed albuterol. Unfortunately for our patient, he was shortly readmitted in the beginning of June, about a week or two after his initial discharge for worsening hypoxemia. At that time, he was then placed on high flow nasal cannula up to 40 liters and then treated with antibiotics, dexamethasone and tocilizumab. And then he was eventually weaned to nasal cannula, but this time discharged home on more oxygen than he was at the previous hospitalization. So previously he was discharged on 2 liters of oxygen and now 3 liters of oxygen, and still having significant hypoxemic episodes with exertion and with sleep. Looking at his images, comparing just from the February to the May, you'll kind of see an evolution of his chest x-rays as he progresses through his illness with COVID-19. You can see the ones obtained in June, increased GGOs bilaterally throughout a very short period of time. And then post-hospitalization, so he was seen via a telehealth visit in ILD clinic, reviewed the outside images, and then at that time we were noticing that he was still pretty hypoxemic, desaturating into the 60s with exertion on 3 liters of oxygen, experiencing quite a bit of shortness of breath. His daughter said that he actually couldn't get up off of the couch to even walk to the bathroom just with his symptoms. His home oxygen was titrated up to 6 liters, and with that, he was doing well. At the same time, his insurance coverage ended up kicking in, and we started him on nintedanib at 150 milligrams BID, and then we also continued to diurese him pretty aggressively. And then eventually in July of 2020, when we saw him again, since starting the antifibrinolytics therapy, his symptoms and oxygenation had improved along with kind of diuretics, as I mentioned earlier. And then subsequently, we had repeat CT chest PFTs done in order to kind of see where he was evolving and where his lungs were in terms of status. This is the repeat CT that we did in July of 2020, kind of comparing it to the old. You can see a little bit more fibrosis here at the bases that he's presenting with. I'll play that through one more time. And then you see, again, evidence of paraseptal emphysema quite extensively bilaterally. And then we repeated PFTs, and again, kind of looking at some key factors here as far as his ratio, FEV1 to FEVC was still okay. TLC was, quite a bit reduced from what it was back in February, if you remembered. It was down to 69%. And then really looking at the market decrease in the DLCO in his repeat PFTs and functionality, and showing the diffusion limitations that he had after being sick with COVID-19 and kind of the impacts on that. And then again, just for comparison to where we were in February to now where we were in August of 2020. And that brings us to a few questions, and I'd love Dr. Jisha Joshua to also weigh in here, because she is taking care of a lot of these patients in her outpatient settings. And everyone who's participating, we'd love to hear your thoughts in the chat box in terms of really how has your outpatient management of ILD patients changed during the COVID-19 pandemic. And I'll pass it over to Dr. Joshua to talk a little bit more about her experience and what she's seeing in clinic.
Thanks, Brinda. Thanks for presenting that case. Yeah, so that was my patient in the outpatient setting, and he was admitted outside, so I did not have a lot of control over what was going on in the other hospital. But when he came back from the hospitalization, he was extremely sick as compared to what he was when I saw him initially for his initial. So that's something that we've been seeing, especially in this in the interstitial lung disease or diffuse parenchymal lung disease patients, that they are already pretty sick, but once COVID hits them, if you see, his CT, it wasn't very clear on the slides, but there was a lot of ground glass opacities on the CT in the areas of the lungs that were normal before, and that is what has probably affected his DLCO to such a significant extent. So now we know that already with compromised lung function, if you have an additional insult with COVID, which in many cases lasts for a very long time. We have been seeing that it's taking months for these opacities to resolve or sometimes progress onto fibrosis, that these patients will be left with much more severe deficits in the future. So our management actually changed for him. Now we are considering him for a transplant evaluation and, repeating his echo to make sure his pulmonary hypertension is not worse. So in general, it's been a very challenging time, and I'm sure for everyone out there, it's been very challenging, especially in patients with interstitial lung disease who are already, socially isolated and are dealing with a lot of symptoms. Now, adding on COVID, they, tend to screen positive for all the questionnaires. They are more scared now. They are worried that if they do get infected, they're going to be super sick. With all those things in mind, these patients are becoming, even more anxious and depressed. So I think it's our responsibility to make sure that we do not, from our, providers or physicians standpoint, do not make the care any worse, and make sure that they are followed up regularly. So in our clinic here, we have kind of kept the same degree of follow-up, or if not more, because we have switched to a lot of visits to the home health version or the televisit version. And what we are doing is that initial visits, so if there is a new patient evaluation, we are seeing them right away as a telehealth and then evaluating them for their symptoms, whether they are chronic or acute. And the next visit, the second visit, we are offering them as an in-person, just to make sure that we can get a good history. We can do all the stuff that we can do without needing to examine the patient in the first visit with our telehealth visit. And then once we have that long visit over, as you know, we need a long time for getting all the history. Once we are done with that, we have a shorter in-person visit after that, mainly for examination or oxygen testing. So we are trying to modify the visit type. We also get COVID tested if testing for these patients if they are having acute symptoms before bringing them to in-person visits. So a lot of changes in the staffing, how we disinfect rooms, all those, of course. In terms of outpatient management, not significantly changed, I would say. I mean, in terms of treatments, we have continued patients on their antifibrotics if they have already been on them, and we have initiated antifibrotics on patients who have not been on. Just being aware of the fact that some of the side effects from antifibrotics like transaminitis or GI side effects could mimic COVID, and if they are having any symptoms related to COVID, to make sure that they are not hidden in those side effects. So taking care of that. Secondly, for immunosuppressions, that's a very debated topic, I would say, and we don't have a lot of literature on it as to what to do about it. At our center, most of the time, if patients are stable on their immunosuppressant, again, I would say it depends on the area and the COVID burden. But in our center, we have been continuing the immunosuppressants. If they are new patients who may require immunosuppressants, we are dealing with that on a case-to-case basis. And if they are relatively stable in their PFTs, maybe delaying initiation of their immunosuppressant to a later date. And if they are kind of progressive or showing that progressive phenotype, then explaining the risk of immunosuppression and do start them on immunosuppressants.
Great, Jisha. I'm just going to ask Dr. Joshua, since he's on the call, what to compare and perhaps contrast experience at National Jewish. Are you following, how have you adapted your evaluations of your ILD patients during this time?
So that's a good question. I mean, we've done similar things to Dr. Joshua. We have a mix of, my clinic is obviously a mix of patients with idiopathic pulmonary fibrosis on antifibrotics, and then we have a number of patients who are on immune suppression. So we are trying to minimize visits if possible. So there's a lot of telehealth appointments. I'd probably echo what Dr. Joshua said about the medications, nintedanib. I mean, we can discuss maybe later, do these patients have flares of their ILD when they get COVID? So is this an acute exacerbation? Is that what your patient had in the hospital? Nintedanib probably has an effect on acute exacerbations. And so are these medicines we should be using? You know, immune suppression is an interesting topic to discuss because immune suppression may increase your risk of getting the virus, but if we, you know, this inflammatory surge that we're seeing in the hospitals where patients get this intense inflammation and especially, you know, lung injury, you know, does the presence of Cellcept or azathioprine mitigate that injury? And I don't know the answer to that. I can tell you from our experience at National Jewish, we have a fairly large ILD group. We're seeing very few of our patients in the hospital. And that's one of two things. Either they are somehow protected from COVID, which I don't think, or they know they have a lung disease and they know they're on medications and they are not leaving their house. So I think in terms of social isolation, our ILD patients have done really well, but we are seeing them come back with more fibrosis. And is that an acute exacerbation from just having a lung injury from COVID, or is this something direct to COVID? I don't know, but we're learning, just like you are, Dr. Joshua. So I think it's keeping our patients safe. And then, you know, and one final point, in terms of therapies, I haven't done a lot of therapy changes during the COVID era. You know, if there's someone marginal for immune suppression, maybe we would hold that, maybe not initiate it. But I do think, based on some of the data emerging on fibrosis post-COVID, if I had COVID and I had ILD, I would want to be on an antifibrotic because I think a lot of these patients, because for their extended time on ventilatory therapy, we're seeing a lot of fibrosis. I think there's potentially a role for antifibrotics, but I think we won't know that for some time.
That's great. So just continuing on, Jisha, Dr. Joshua, what would be your threshold to admit a patient with ILD who is COVID positive then?
So I would say I would have a very low threshold because I know that these patients can deteriorate pretty rapidly. And as Dr. Salman was mentioning, we don't know if it is a COVID or is it an exacerbation of their ILD itself. So even patients who may not have a significant oxygen requirement, who are just beginning to have their symptoms, I would say they should be evaluated at least first in a telehealth scenario. And then depending on how you feel, how they look, you know, based on comparing to what their baseline was, have a very low threshold to send them to the ED and be monitored. And then as soon as they are in the ED, have a communication with the inpatient team that, hey, my patient is there, please, you know, monitor him closely, so that if there is any deterioration, there is a quick, not just about therapies, but also start a discussion regarding palliative care, because many of these patients, if they are going to get worse, they may not, you know, come back, or they may need intubation. But intubation in these patients, already you have ILD, which has a very high mortality if you get intubated, and COVID, if intubated, has 80 to 90% mortality if you're intubated. So if you combine both of those, you can only imagine what the chances are of them surviving. So having an early on palliative care discussion may also be needed in these patients. So I would say have them admitted early.
So just following up then, moving on to question 3, and any recommendations for the treatment of COVID-19 pneumonia in patients with ILD? And I'm just going to throw this one out. Like, so presuming perhaps that you didn't already know the patient had IPF and you admitted somebody with COVID who looked like they had pre-existing IPF, would you consider starting an antifibrotic during the hospital admission? I'm not sure if that's where you're going with that question, but I'm just going to throw it out there.
So I don't think there are any recommendations specifically for ILD patients who get COVID, but I would say we would do what we do for any other patient with COVID-19. Differences being that maybe we may cover them routinely with empiric antibiotics more than a usual patient because of their risk of maybe having a superimposed pneumonia. If they were on an antifibrotic, I would say to continue, but to start a new antifibrotic might be an issue. As you can see, my patient took 3 months before he could start his antifibrotic as an outpatient. So getting a patient approval as an inpatient, I think, would be hard. I think there are some trials that are running to see effects of nintedanib and pirfenidone in COVID patients, but I don't think it'll be easy to get it. But I would say if they were planning, so such as my patient, I was already planning him to be on nintedanib and he could not, and I would not have said, don't start it. The only caveat that I would say is that if the if COVID-19 is active and the patient is sick, they would have probably renal failure or liver abnormalities. And then you are starting a new medication that has similar side effects or lab abnormalities, and that can muddle the picture a little bit. So you have to be careful about starting something new like that the patient has never been exposed to. I think it'll need a few clinical trials before we can say whether antifibrotics would be useful if started during the COVID-19 pneumonia.
And then Dr. Joshua, if someone is on antifibrotics already coming into the hospital, as far as, one of the things we've seen with COVID-19 patients are, whether they're prothrombotic or the rates of thrombosis and anticoagulation. And, at some institutions, the prophylactic doses of even with anticoagulants are a little bit higher doses. I guess in terms of kind of the increased bleeding risk, if they're already on antifibrotics, are there guidelines that you've given to patients who get admitted that are on these medications as far as what to do with their anticoagulation?
So I would say, again, no guidelines or anything, but I would say if you were already on an antifibrotic, if you don't have an active contraindication, I would continue them. If you do see renal failure or transaminitis, you may need to temporarily discontinue or dose adjust them. If the patient is, again, all the patients should be on prophylactic anticoagulation when they're admitted. So I do not think that should be a contraindication to continuing their antifibrotic. But if they were to need a full dose anticoagulation, I think we may have to temporarily discontinue nintedanib just because of the theoretically increased risk of bleeding. But again, there is no studies that support, or second that, but I would think that would be a wise thing to do. I would also ask Dr. Solomon if he has any ideas about that.
Yeah, I don't disagree with anything you're saying. I think the bleeding risk with nintedanib, as you know, in the studies was small, but is there. Maybe that's a benefit to these patients who are procoagulant. I don't know. And I know that a lot of us, as we're doing this here, are making things up. I hate to say that, but making things up in terms of anticoagulation when your D-dimers a certain number based on some early path studies. Doing that, I just, of course, I would caution anyone to do things outside of some good data. But yeah, I think continuing their antifibrotics, when you look at some of the path studies, these small case series of, you're seeing, not only you're seeing fibrosis in these, thrombosis in these lungs, but you're seeing fibroblasts and collagen deposition. And so to that question of should you start it during this? No, because we don't know, but there are clinical trials going on. And I think it's somewhat plausible to say, I'm going to arrest fibrosis in the patients who have prolonged ventilation because we're seeing a lot of fibrosis. So I think clinical trials are the way to go for that. And so, and I agree, I wouldn't stop those medications unless I had to.
So we have a comment from the chat box about that IPF patients with atrial fibrillations, for instance, tolerate both antifibrotics and anticoagulants just fine. Comments from both of you?
Yeah, I think it has to be done on a case-to-case basis, but I think when patients are admitted in the hospital, they're potentially sicker if they especially have concomitant other organ involvement. So I would be careful in terms of that also, especially if they have an AKI, which that also puts them at a higher bleeding risk. So I think it wouldn't be wrong to say, like, if you're on full dose anticoagulation, there is a risk of bleeding. But if you were to continue, I don't think there are any guidelines to say you should not do this or you should do this. I think these are.
I agree. Sorry to interrupt you, but I agree with you. I think don't forget there was a signal on a warfarin trial with IPF that anticoagulation potentially increases mortality in IPF. So, I don't know what you're going to do if someone's hospitalized and they've got COVID and they have thrombosis. Anticoagulation probably increases mortality in patients with IPF, but that's long-term. And I think the short-term mortality of COVID and PEs is much greater. So these patients do tolerate anticoagulation. I think, if they're COVID positive with thrombosis, I think anticoagulation is we're kind of forced to do it.
Great. Any other comments from our audience? Dr. Desai, do you want to move on with the rest of the questions?
Yes, and I think we've hit, most of it in terms of the antifibrotic therapy and then additional recommendations. And then I think, Dr. Joshua touched on this a little bit in terms of patients who are admitted to the ICU and that do require intubation, kind of having conversations early on, even in terms of goals of care and kind of management of patients, just with their increased risk of mortality, with having ILD requiring intubation, and then on top of that, having COVID. So I don't know if there are any other thoughts that either Dr. Solomon or Dr. Joshua had, or specifically patients who are admitted to the ICU and do require intubation, aside from kind of the standard of care that we provide to COVID-19 patients right now with remdesivir, antibiotics, steroids.
Yeah, I would say that in all ILD patients may not have severe disease, underlying disease. So if they are mild, you know the patient from your outpatient. If they are mild disease, I would say they may be able to tolerate an intubation. Again, having very close monitoring is required. Patients who might be transplant candidates, they should definitely get the full care if they are listed. But again, if patients are not listed or evaluated for transplant, then it may not be a good idea to intubate them. Other than lung protective ventilation, early proning, I think that those are the main things. Antifibrotics cannot be given cannot be given through a G tube. So they may have to be discontinued if the patient does get intubated.
I want to echo just one comment by Dr. Joshua that, these patients already have fibrosis, they're stiff, they're compliant, they have low compliance, and if you do intubate and ventilate them, we all should be good about low tidal volume, low transpulmonary pressures anyways, but I would be especially careful in these patients in terms of keeping your plateaus under 30, keeping your driving pressures close to 15, and really making sure that you are not over-distending these lungs in patients with pre-existing fibrosis. I mean, it's a risk to flare, it's a risk for propagation of fibrosis. So yeah, I would just echo that, really be adherent to low tidal volume, low driving pressure ventilation.
Okay, we have one more question from the chat box. Do you have any information or data regarding whether the mortality is increased in patients with COVID and ILD? And to follow that up, is there any rationale for giving these patients a higher dose of steroids in the event they're having a concomitant flare?
I'll answer the mortality question because it was just released in the Blue Journal. And so Gisley Jenkins and colleagues in Europe just released it. I think it came out yesterday, showing they looked at their ILD patients and they clearly had a higher mortality, and the ones that were overweight and older did poorly. So I think it's what we would all guess, right? If you have ILD and you get COVID and get hospitalized, you do poorly. And I don't know, Dr. Joshua, what do you think about higher doses of steroids in these people?
Yeah, so I would say, as we know, dexamethasone is now recommended for patients who are requiring oxygen or who are critically ill. So I would say that should be used in patients with ILD. Patients with IPF, we know steroids long-term have a negative impact on them. So, and also in ILD exacerbations, not necessarily have any, benefit, if any, could be actually worsening using high-dose steroids. So personally, I would not that we should do significantly higher doses of steroids. Now, if a patient has, complete ground glass opacities and is looking extremely sick, and you have no other options, you could maybe give a trial of high dose steroids, but I would not start with that.
Great. Just in the interest of time, because I want to make sure that there's enough time for the next case, I'm just going to ask Dr. Solomon to comment about the phenomenon of post-COVID fibrosis. Is it post-ARDS fibrosis? What is it?
Yeah, thank you. I'm going to share my screen. I'll be brief because I know we're a little behind, and I don't have answers to the questions you just said, but I'll I will say what I think, if that's helpful. So, and this will only be a couple minutes. So can you see my screen there? Okay. So I have an interest in this and I'll tell you why, just because during the, first off, I do interstitial lung disease in clinic, but also I spent a couple weeks in New York during the height of the pandemic, and we were seeing a lot of this. And so I think I just want to touch briefly on what we were seeing. So this is just a typical case of prolonged ventilation in someone with COVID. And so this is a 74-year-old male, spent a long time on mechanical ventilation, and this is what the scan looks like at day 45. And so you can see there's obviously reticulation, there's ground glass in there. There's a lot of infiltrative lung disease throughout. And so we know that ARDS survivors have fibrosis, especially those who go through fibroproliferative ARDS. And so this is a typical scan that we would see for someone 6 to 12 months out. They have this anterior reticulation. It's not peripheral. It's kind of in the actual distribution. You can see it more proximally. And it's been known for a long time that it correlates obviously with restrictive physiology. These patients do worse if you have fibrosis post ARDS. Okay, so we see this, and what we do know is that at 1 to 2 years, a lot of this gets better, and so a significant amount of this resolves, though there are persistent changes. So if you look back, we have some preliminary data from the original SARS in 2003, which had the most data comes from that, and it's going to mimic or mirror what we're seeing, I think, with COVID, which is within 2 weeks, you're starting to see reticulations in those with prolonged disease. And if you look out at 4 weeks, in at least one study, half of them still had reticulation. And then, if you really search for the ones that are really short of breath afterwards, you're going to see that they have fibrosis. And it correlates in at least SARS-CoV-1 with patients who are older, longer in the hospital, and higher inflammatory markers. So all that makes a lot of sense. MERS, unfortunately, for some reason, we don't have a lot of data on MERS. There was a chest x-ray study, which is not very helpful, but they also saw chest x-ray findings for fibrosis. And if you look at the H1N1 in 2009, I believe that was, we have data on H1N1 too, that they had a percentage of post-disease fibrosis. So what's going on in COVID? I don't know. There are some PATH series that are out there that are describing, fibroblast proliferation in these patients, some microscopic honeycombing. And again, as I said, at the time, of course, it seems similar to SARS and MERS. My questions would be, and I don't know this, we have funding to look at this. So we're looking at people in NYU who have been on ventilators who've had respiratory failure, looking at fibrosis. But, is it the fact that these patients, when you get on a ventilator with this disease, you're on a ventilator for 3 to 4 weeks. Maybe it's just bad ARDS. And maybe it doesn't look like, and so what we're seeing is peripheral basilar predominant disease, similar to the idiopathic interstitial pneumonias. And maybe it's because we're proning everyone, right? I mean, a lot of ARDS back in the day, we didn't prone a lot of people. And so maybe this injury the distribution is different. And maybe it's because they're on a ventilator for 4 weeks. Does it resolve? We won't know that for 6 to 12 months. And can we prevent it? I mean, obviously these are questions. And I'll end with some real life pictures from what we're seeing. And so I spent some time at NYU, and they've had a lot of people on prolonged ventilation. So these are just images, and these do not mirror the images of what we're seeing with post-ARDS, right? And so you can see some peripheral traction bronchiectasis and reticulation, more basilar predominant. Here's another patient who has a little more consolidative opacities, but also has some more anterior disease. And then obviously we're seeing someone had commented in in the comment section about some of the barotrauma. We're seeing that here. A lot of these patients are having barotrauma, but this patient has a lot of traction bronchiectasis and reticulation, seen better in this coronal images. So, 9% of the population has interstitial lung abnormalities. So maybe that's who these people are. Or maybe they had ILAs walking in the door and got COVID. I don't know. But I think we need to answer this question because COVID's not going away. And I think if we can learn who's going to get fibrosis, maybe we have a therapy to prevent it. So I'm not in any way an expert. We're seeing it, and we're going to learn a lot more in the next couple months.
Thanks, Dr. Solomon, and thank you, everyone. Now we're going to move on to speak with Dr. Stephanie Christenson from UCSF.
Okay, I'm going to share my screen, and Sarma, who is also with me at UCSF, is going to share the vignettes. All right. So, yeah, so I'm Pulm Critical Care at UCSF. So I'm going to kind of talk about obstructive lung disease, asthma, and COPD, really a little bit more in the context of critical care, although happy to also talk about, what to do with them after they leave the hospital. But I think Dr. Sarma is going to share a couple of vignettes to just kind of give a picture of what we're seeing in our ICUs and how I'm thinking about them. Okay. Aartik, are you there? Just so. Oh, I don't know.
Sorry, I was muted and I could not unmute myself. But great. All right, so we're going to start with a case that's fairly representative of the patients we've been seeing here in San Francisco. We've been fortunate to have a relatively low burden of COVID in San Francisco, but insofar as it has hit the city, it has disproportionately hit minority populations. And so start with the case of a 44-year-old Latino man with a history notable for asthma, obesity, and hypertension, who presented with flu-like symptoms for 3 days, shortness of breath for a day, lives with 2 other people who are also presenting with similar symptoms, and has a job that exposes him potentially to lots of other people. His home medications are consistent with his comorbidities. So he's on a low dose of Flovent, not particularly severe asthma at baseline, hydrochlorothiazide, and albuterol PRN. His vitals on presentation are 92% on room, he's 92% on room air. He's a little tachypnic with a respiratory rate of 24 and mildly hypertensive with a blood pressure of 155/72. So he's admitted to the hospital, and on day 1, he's known to be COVID positive, and he's admitted to the floor on 2 liters nasal cannula. Day 2, his O2 requirement gradually increases. Now he's up to 6 liters of nasal cannula. And then day 3, his O2 requirement rises to 20 liters high flow. And I should note that at UCSF, generally, we run high flow at 100%. So it's a pretty substantial O2 requirement. Transferred to the ICU, and he started on remdesivir and dexamethasone. Then increased to 40 liters high flow, non-rebreather, and ultimately is intubated and started on ARDSNet protocol ventilation with a high PEEP. His chest X-ray looks like this. It's pretty classic for ARDS. And he started on ACVC with a tidal volume of 360, a set rate of 28. He's not overbreathing. He's on an F of 0.8 and a PEEP of 14. On those settings, his PIP was 38 and his plateau was 31. So before diving into his management, we'll talk a little bit about his asthma history. He was diagnosed in childhood. As you saw, he's on a low dose of Flovent. Uses albuterol 1 to 2 times per month for wheezing with exertion. So his symptoms are really quite well controlled, no nighttime awakenings, and his usual triggers are upper respiratory infections, allergens like fragrances, and he had 1 exacerbation as a teenager for which he required prednisone, but hasn't required steroids for a long time.
Okay. So I'm just going to kind of talk quickly about this. So this is kind of a usual case, like we said, that we're seeing at UCSF, where we're getting these patients who come in with multiple comorbidities that often includes asthma, but that they're not looking a whole lot different than any of our other COVID patients. As you can kind of tell, that sounded like a kind of typical COVID patient. They didn't sound like they were having an asthma exacerbation, which is particularly interesting because with asthma, the usual triggers for an exacerbation are viruses, maybe wildfires. We live in San Francisco. It has been kind of interesting as we've been thinking about asthma management in the setting of COVID, where we've been seeing actually quite a few patients coming in with asthma, but we're just not seeing the kind of typical severe asthma that would otherwise be a problem in our ICUs. So I just wanted to go through a little bit of the data on this and suggest that we're not the only people that are not really seeing much. So I know Dr. Wang and I, when we discussed this call, we were all kind of saying, hey, well, our asthma patients are mostly staying home and trying to take their medications. And actually there's data suggesting that, that they're scared. And so they are mostly staying home. That said, we are seeing some patients come in, and this is just kind of a representative report of this from Northwestern, published not that long ago, I think in early August, where they were saying basically that they were seeing maybe about 15% of the patients with COVID coming in had a history of asthma. Of their patients diagnosed had a history of asthma, but that it didn't seem to increase the risk of hospitalization, and that inhaled corticosteroids were also not associated with an increased risk of the hospitalization. So this has been kind of representative of what people have been reporting in the literature. Although notably, actually, the first reports out of Wuhan were that there was almost no asthma, and that was interesting in that it was much lower than their normal, the normal incidence in their population. So it was lower, and this is actually suggesting it's maybe slightly higher than what they would normally see in their population, and I think people are seeing that in general. But what I'm showing here on the side is that, well, actually a lot of these asthma patients also have kind of other comorbidities that are particularly relevant to COVID-19. So potentially the reason that you're actually seeing more asthma patients is because a lot of these patients also have obesity, hypertension, diabetes, obstructive sleep apnea, coronary artery disease. So the other comorbidities that would make you a candidate for more severe disease. Okay. And then this is just another one out of New York Presbyterian, kind of suggesting pretty similar things, that they weren't seeing that these patients were doing worse. So the asthma patients in general were doing worse. And I'm actually interested here in the chat box if people were seeing asthma exacerbations come in with COVID-19, because I'm just not. There was one report out of the UK, a pretty large study that did suggest that there was maybe some association with more severe disease, but that was kind of one of the more outliers. And this is different than what we're seeing with COPD, but I'll talk a little bit about that next. And then again, like I said, so asthma, so I was saying I'm not really seeing exacerbations with asthma and COVID-19, and this is actually also reported in the literature. This is out of University of Paris, and where they saw about 5% of the hospitalized patients had a history of asthma, but none of them presented with an asthma exacerbation, and only 6 of the 37 patients had any wheezing in the hospital, and that was in general mostly mild. And so the patients who tended to do worse were, again, these patients with comorbidities, and 84% of the patients that were hospitalized had a BMI greater than 25. So obesity was a particularly big deal, and we also see, obesity can be associated with certainly worse symptoms and occasionally worse exacerbations in our asthma patients. And then the other thing that I'm kind of showing in this slide here is that one of the, we've been thinking about why this is. So why is this biology, or why are we seeing this epidemiology? Is there some biology to it? And so even out of the first, some of the first reports out of Wuhan suggested an eosinophilopenia, which most people don't have high eosinophils, so I'm not exactly sure what that means, but at least that they had low eosinophils. And so at least the asthma subjects who came in this study had approximately the same levels of eosinophils as the controls. And why that's interesting is because usually you would see with patients not on steroids who are coming into the hospital, they should have at least a lot more of a range of eosinophils. So seeing that they all have kind of low eosinophils, and this has been seen again and again, that we're seeing these patients who have lower eosinophil counts. So does that mean that patients who actually have a more eosinophilic asthma are somewhat protected against the virus? I think that is what people are hypothesizing. Again, that is a hypothesis. It is not something that has yet to be proven, but I think there are multiple studies now ongoing looking longitudinally at some of these patients to see, okay, does there seem to be actual decreased risk, not just cross-sectionally, but in some of these bigger cohort studies suggesting that patients who are eosinophilic or who have type 2 inflammation in their lungs actually don't have high risk for COVID-19 severe disease. So what to do with your asthma patients when we're thinking about how to treat them, either in-house or if they're nervous. I've had multiple patients say that they're nervous about starting or continuing biologics in the COVID era. But the biologics for asthma, as opposed to the biologics for many other diseases, they're really targeting the eosinophil, they're targeting the type 2 pathway, which really should not be suppressing the antiviral response. So continuing them should not be causing problems for your viral response. Now, again, we also kind of think similarly for inhaled corticosteroids, the kind of cross-sectional observational studies out there aren't suggesting that inhaled corticosteroids are causing problems, but that is certainly something that I know people are considering there might be some equipoise on, but again, do you really, having a patient now be uncontrolled for their asthma and potentially come in to the hospital when they wouldn't otherwise need to is not ideal. We do suggest continuing to use oral steroids for exacerbations, but I guess, when we're thinking about these patients who are on oral steroids continuously, that's another question. I will say for me, I really try to get any patient as possible off of oral steroids for chronic use, just in general. So hopefully the only patients I really have on oral steroids who have bad asthma really need them. So they probably should be continued while I'm trying to potentially transition them to a biologic. And then the other thing, obviously, so as we're talking about patients who are in-house, replacing nebulizers with MDIs, we've obviously talked about this quite a bit when they're hospitalized, that you're trying to decrease aerosolization. So if you can replace nebulizers, that we should be doing so. Okay. And this was just a little bit of the biology of, hey, whenever anybody talks about the biology of COVID-19 and why you might be more susceptible or less susceptible, everybody's looking at ACE2 levels. How much that matters, I'm not completely sure, but I will say that what people have been showing is that ACE2 levels, which would be the receptor that binds the spike protein for SARS-CoV-2, we have been seeing kind of across data sets, and one of these is the bronchial epithelial one from the severe asthma cohort is my data, but also in sputum and in nasal swabs in children, we're seeing that ACE2 levels are at least slightly lower in asthma and with type 2 high inflammation, and that in the sputum that actually inhaled corticosteroid treatment seems to be associated with lower ACE2 levels as well. So maybe there's some biology behind why asthma may be less of a risk factor for severe disease. All right, so with that, we also wanted to kind of present a case of more obstructive lung disease and consider how we would potentially treat a patient like this when they come into the hospital, particularly since I know we've got trainees or people who are not necessarily critical care trained. And so how are we going to treat these, how are we going to ventilate a patient appropriately? Okay, Aartik.
Sure. So now the second case is an 86-year-old Caucasian male, 45 pack years of smoking history of COPD. His FEV1 is 45% of predicted, and his history of hypertension now presents with cough, fevers, and shortness of breath over the past 3 days. Has a productive cough at baseline and intermittent wheezing, as you might expect, given his FEV1, but his last exacerbation that required steroids was 3 years ago after developing a URI. He's currently on a combination LABA-LAMA and uses albuterol 3 to 4 times daily. Was intubated in the emergency department because of an increased work of breathing, and he is COVID positive on rapid testing. So in terms of brief exam and labs, his ABG in the ED was 7.11, 74/70 on volume control. Don't have the initial settings, and an F of 0.8. So then his heart rate is 135, his blood pressure is 95/47, and the ventilator starts alarming on settings of a tidal volume of 450, a set rate of 16, an F of 0.8, and a PEEP of 14. He is breathing at a rate of 19 compared to a set rate of 16. His PIPs were ranging from 48 to 54, and his plateaus are between 32 and 34. On exam, seems to be pushing against the ventilator, is not wheezing, as tachycardic, and his extremities are cool.
Okay, so I guess the last thing I just wanted to have a few points on how we deal with severe obstructive disease in these COVID-19 patients, because now you've got, instead of earlier where we were dealing with our fibrotic patients who also had ARDS, where at least they were they both just had low compliance. Now you've got a compliance issue and you've got an obstructive issue. And at least with my trainees here at UCSF, I feel like people are not as used to seeing obstructive disease in our ICUs when it's all just COVID ARDS. One thing, so when we're talking about COPD, as opposed to asthma, we are seeing that that's associated with worse outcomes, and that's potentially due to age, frailty, more than the actual disease itself. Although if we're talking about one of these patients where we're talking about really severe obstruction, where it's actually causing, ventosynchrony, really high peak pressures, over your plateau pressures. In this case, we're actually talking about potentially either small airway disease or air trapping, maybe some large airway disease. The patient looked like they might have a little asthma COPD overlap, given that they'd had some chronic bronchitis type symptoms. So it's a little difficult to tell, but exactly where we are with that. But with these patients, so dysynchrony is a huge problem with their ventilation. And so often my first goal, once I get one of these patients up to the ICU, is just to get them to stop interacting with our ventilators. And so sometimes that means that I'm just paralyzing them pretty quickly right off the bat. And I think with our ARDS patients, now we're doing that pretty quickly as well. So maybe it's less of an issue, but when I'm having a really hard time, that's oftentimes where I'm going. And of course, now these patients, as opposed to our ARDS patients, we're going to have to give them more time to exhale. And that often means that I'm going to increase my expiratory time, and that's either by increasing my inspiratory flow or decreasing my inspiratory time. Fortunately, we've got one thing that all kind of works together, is that I'm going to be trying to decrease my tidal volumes as well as decreasing my rates. And oftentimes I'll end up having to disconnect the patient to get them to exhale fully, but obviously that's something that I really can't do in ARDS, because I'll probably particularly with one of these very, very sick patients, that I may lose ground and have a hard time getting them back. So oftentimes I have to be really careful in just playing with the ventilator at the bedside when I'm seeing something like this. And we're almost out of time here, so I'm gonna kind of move on. But so when we're talking about high peak airway pressures, so then we're oftentimes talking about not just low lung compliance from the ARDS, that we're also getting high airway resistances from the, in this case, from the COPD. We're thinking about both the small airways, potentially somewhat the large airways, and then large amounts of intrinsic. So just a reminder that we're talking about asthmatic lungs or potentially these COPD lungs or our bronchiolitis obliterans lungs, where they're just going to keep going up in volumes. And so one of the things that we really want to be careful about is trying to match our extrinsic and intrinsic PEEP, so that as we're ventilating these people that we're allowing them to be able to take breaths out, meaning that if we're auto peeping, that's what the pleura is seeing, and that's what our alveolus is seeing, but it's not what we're seeing at the mouth. So what we need to do is we need to match that extrinsic peep so that we're allowing the air to get out. It also allows the patient to be able to trigger the ventilator. So just, again, I was just going to do this really quickly since we're right at time. So when in doubt, like when we're thinking about this, really trying to permissive hypercapnia, and like we talk about it with our ARDS patients, but these patients, again, we might end up having to get their PCO2s, we're talking like 90s, 100s, and I may end up having to start bicarb drips to help them once we're going up to these levels. Low tidal volumes with low respiratory rates, PEEPs that are really close to the auto PEEP. So if you're measuring an auto PEEP, let's say at like 6 or so, you want your extrinsic PEEP to be about 80% of that. And then IDE ratios of 1 to 3 or plus. So, and many people prefer pressure controlled ventilation. So that was just kind of a very brief primer on what we do with obstructive disease as well in the ICU. Okay, I think that was it.
Great, thank you so much, Dr. Christenson. So we do have a little bit of time to go into the chat box to answer some questions. So there was a question in here about how common secondary spontaneous pneumothorax was in patients with COVID.
How common spontaneous pneumothorax is?
Yeah.
I've certainly seen it, and I think other people, I don't know if other people in this call have seen it. Yeah, I have certainly seen it. But I don't know, I wouldn't say I know exactly. I don't know the data on it, on exactly how common it is. But certainly once you've got fibrotic disease, or you're getting into the kind of fibrotic ARDS, if you get and you get barotrauma, you can certainly get spontaneous pneumothoraces.
And Dr. Wang posed a question about seeing post-viral airways hyperreactivity in post-hospitalized coronavirus patients. In outpatient clinic, I see this pretty frequently.
Have you been seeing a lot of like the COVID-19 related to COVID-19?
I think so. They have the initial cocktail in the ICU, and then post extubation they end up having like a protracted viral airways that's post-infectious.
Kind of like post-infectious cough.
Yes, exactly. And then I've also been seeing some chest pains as well. Mm-hmm. Yeah.
Yeah, I think it's interesting because I think when we're saying, we're not seeing a lot of, again, like that kind of wheezing asthma, like the wheezing asthma patients that I've been seeing, and again, other people may have other experiences that I haven't been seeing it in relation to COVID-19. too much, but it's interesting to hear you're kind of seeing and again, this kind of post-viral, like coughing. I don't know if they were having a lot of wheezing for you, Dr. Liang.
Unfortunately, I haven't been able to listen to their breath sounds because they are usually through telemedicine visits. Some of them do, and then some of them don't have the wheezing component, though, from a subjective history taking perspective.
So my practice is primarily non-hospitalized post-COVID patients, and we were just talking about this before the forum, but obviously patients get referred to me because of their symptoms, which is primarily cough. So yet behaving like they have post-viral airways hyperreactivity, which makes sense. I mean, you know, with the viral infection. But again, the cough, shortness of breath, and chest pain, normal pulmonary function, clear chest x-rays, no wheezing on exam, but they do seem to get better with, you know, your ICS LAMAs.
Yeah, that's interesting because it's not necessarily what we're seeing, at least not what I'm seeing in-house. But it is interesting because that's how I would normally treat them, right? Like,
right.
That's what I would give them.
You don't have much else to do.
That's what I would do. So, yeah, and I think at least we're not seeing that it's causing any harm. I mean, they tend to be generally pretty safe.
Yeah, I mean, these are 3-4 months out from their original infections, and sometimes patients are surprised because they weren't initially very ill, but then they have these lingering symptoms.
Yeah. Yeah, absolutely. It's interesting. I think I'm seeing some people posting on not wanting to disconnect the ventilator in a COVID patient. I totally agree with that. I will say that sometimes though, yes, if you're in full PPE in a negative pressure room, we have had some where we have had to disconnect. But again, hopefully you are wearing full PPE, like with, you know, if you're doing something in an aerosolizing room that you're using, I would be wearing a PAPR, just the same as intubating. I will say we haven't had any, at UCSF, we haven't had any issues where we've had any COVID positive healthcare workers in relation to intubations or in relation to like disconnecting the vent. But obviously we do not try to do that if at all possible. So again, you also probably don't want to do that just in general, where, you know, I would prefer not to de-recruit my patient, even if I were, didn't have COVID. So it's very tricky in these patients who have obstructive disease, where you're trying to play with both their airways and their lung compliance.
Thanks, Dr. Christenson. And then there's a question about the type of steroid that's preferred in acute severe asthma in COVID. And I think that we've seen dexamethasone be used a lot. Does that differ in the outpatient setting?
Well, I mean, I think we're using dexamethasone for severe COVID. So I think once you're on basically on oxygen, or at least starting to get towards the, you know, very severe or towards the more severe COVID, then we're thinking about doing dexamethasone for the trials. I will say that, you know, at UCSF, we've been very nervous about dexamethasone in general. We get nervous about using things too early, especially knowing the mortality rates with flu. So, and knowing that if we suppress an antiviral response too early, that we could cause problems down the road. And I think that is, you know, from those initial trials suggesting that people not on oxygen didn't get benefit from dexamethasone. You know, I think there needs to be more studies, but sorry, that was a little bit of a tangent, but you know, using dexamethasone for COVID, and I would say if I was seeing COVID plus asthma, if I was seeing anything that was severe, I'd probably be trying dexamethasone.
When I've been seeing patients with asthma and COVID, and they're in that post-infectious reactive airway state where sometimes there could be like an asthma exacerbation, I'd treat them just the same as if they hadn't had COVID. So I will start them on a prednisone course to help out with the exacerbation that may or may not have been related to COVID.
Yeah, and I think that is what the guidelines are recommending. So I think you are going exactly as per the consensus statements, which don't have any great evidence behind them, but neither does dexamethasone in an asthma exacerbation. So it makes sense to me.
Great. Were there any other questions for Dr. Christenson from the audience? You can put them in the chat box. And if not, I think we can go ahead and wrap up and thank all of our panelists for your presentations, your expertise in sharing your experience. Super helpful in this time of uncertainty for all of us. So thank you, everyone.
Thanks.